Alrighty, welcome everyone to Empower Speaks Healthcare Talks. So I'm super pumped for our episode today, but before I do that, as always, I'll give you some background information about Empower Speaks Healthcare Talks, and then I will dive into our guest speaker for today. So the purpose of it is, as the name suggests, is to empower individuals. Whether you're a clinician, whether you are a patient, whether you are in senior leadership in the healthcare ecosystem, whether you're an entrepreneur, the idea is to understand their journeys on a personal level, but then also understand in the healthcare space the knowledge that they have. So we want to pick their brains to understand that. So you, regardless of what position you are in, you can empower yourself, right? Because knowledge allows for empowerment. So through these podcasts, through these sessions, we're going to pick their brain to understand that, specifically within the healthcare realm. But that being said, we also want to dabble into digital health. There's a lot of talk about technology and in various areas within society, but healthcare is always the one that's a little bit behind. And so we want to understand why that is. What are some of the concerns? What does that look like? If you're also non-clinical, like myself, I'm on the vendor side in implementations. I do not have a clinical background. How do I navigate those conversations? How am I able to learn that? So I want to provide you with that as well. So that's the purpose of Empower Speaks Healthcare Talks. Now for my guest speaker for today, Dr. Darren Larsen. So he has, his accolades are incredible. I'm just going to mention a couple. I'll give you the backstory of how I met him and how I was able to get him on this podcast. So Dr. Darren Larsen is a family physician by background, but since then he has evolved into various senior leaderships, specifically in the digital health space. So Ontario MD, Accenture, TELUS, KPMG. He's also faculty at U of T. He's on boards, you name it. He's done it. He's still doing it. So I'll hand it over to him in a little bit to introduce himself and give you a bit more information than what I'm able to. But that being said, I want to share the backstory of how I met Darren. And so this is years ago, dating back. I was doing my Master's of Health Informatics at the University of Toronto, and Darren was actually one of my professors. And all the students knew him as that one professor. He is upfront, he is straightforward, he's transparent, he does not sugarcoat things. He will tell you, and his constructive feedback literally helps you, all of us. You ask any of us. And so that's kind of how he started, how I connected with him. He's been my mentor over the years. So I just kind of connected with him last year at one of our networking events. And I asked him, and no questions asked, he agreed. So I'm so excited to have him here today. So I'm going to hand it over to him to start our session. So today I want to cover a couple of things. So 4 themes we're going to tackle with Darren. First is his personal journey. How did he get into medicine? Then we're going to tackle specific areas, the shortage of family physicians in Ontario. Then we're going to tackle artificial intelligence, right? We hear a lot of rumbling about that. Let's get his thoughts on that. And then last but not least, population health, an area that's not really spoken about, but based on my conversation with him is very important. So I'm going to help you understand why that is. So Darren, I'm going to hand it over to you just to help us understand how you got into medicine to be a family physician, and how did you evolve to these senior leadership positions within digital health specifically? So please, Darren, take it away.
Yeah, thanks, Fahreen. It's a pleasure to be here with you. I know we've been talking about this podcast for a bit, and I'm excited to actually finally sit down with you and have these conversations, because I think having a conversation around the topics that are perhaps less known to people or less understood in the background is one of the best ways we can actually take some of the noise away and clear some of the mythology out of this sort of digital interacting with primary care, interacting with patients kind of space. I'm a family doc for the last 35 years. I always wanted to be a doctor, except for a brief flirtation with public relations, where in my university times I worked in the PR department, actually, of the Calgary Exhibition and Stampede Board, which seems very divergent to what I'm doing now in medicine. But yet the skills I learned in PR directly apply to medicine. And I think, as you said, what I excel in, what I enjoy doing is creating clarity, bringing honesty to conversations, kind of distilling complex ideas down to something more simplistic that people can understand and consume and can hopefully work from. And that is what I do every day with patients when I'm trying to explain to them either what this disease is or what their preventative kind of work needs to be, or even something as simple as, look, I know you have this disorder that you don't really feel and you may not understand and you take a medicine for the rest of your life. Let's pick blood pressure or diabetes. Please do it because it's the right thing to do. There's a fair bit of this kind of communication and kind of conversational style in the work of family doctors every day. So I did get into medicine because it was my first love, and went to the University of Calgary and then into Ottawa U for my residency. Initially thought I wanted to be an oncologist, actually, and I still have a very strong love for cancer. So if you see all of the work, a lot of the work I'm doing in boards and volunteers in the space of cancer care delivery, it's because that sort of love of the science of cancer, this really strong interest in that disease, both from a personal perspective, because that is in my genetics. I know this is part of my family, as it is for probably 40% of us, but also because there is so much research and advancement happening in that area. And in the world of family medicine, we help cancer patients constantly. So I find this interaction very clear to me. And I was in the world of pre-oncology at a time where some of the advances we see now are not possible. So deciding point for me to switch to family medicine was in a bone marrow transplant service where almost all the patients were my age. They were on that at that point in time, 75% of them didn't make it out of the procedure. Now, only 25% of them or less don't make it out of that procedure. Significant improvements in the performance of these technologies in cancer. But at that point, I was so concerned that I wasn't going to be able to survive based on just the death and the loss around me, that I probably would not thrive in that career path. So, kudos to those who do well, but switching to a world of primary care made me very, very in touch with the reality of, I think, medicine, the reality of people in their everyday lives. And what I love most about it is being able to build that relationship up with patients over time. And I had 21 years in a practice before I got much more into the world of health policy, health leadership, and digital health. And then now have been working very part-time in primary care, mostly through the urgent care environments, initially in Women's College Hospital and now up in Collingwood. And I actually am really enjoying that as well, because that brief moment of time you have with people to solve their problem that they're coming in with that day is equally as important in terms of the communication, the style, and the knowledge as it is having a long-term relationship with the patient for decades. So I'm really happy there. In terms of getting into leadership and this world of digital health, it was kind of a twisty, turny route for me. It's not as though I had big intentions to do what I'm doing. And I always kind of approached this from the point of view of you never quite know what's going to be good for you till you get there and start experimenting and opening a few doors. If a door opens and it looks interesting, I tend to want to walk through it. If it's not so great, I find ways to walk myself back or switch. But I walk through a lot of doors. I say yes to a lot of things, which in my mind just leads to the endless curiosity in healthcare and the changes we're going through every day being kind of filled and expanded. And then as well, keeps me in a state of continuous learning. So my journey to all these spaces has only been because I've been continuously interested in what that area looks like and want to dive a bit more in. I did get engaged in leadership through the hospital structure first, as through the 5-year medical staff executive onto the hospital board and foundation, et cetera. Then moved over into the primary care transformation area in Ministry of Health for 4 years. This is in the early 2000s, as we were building family health teams in Ontario. And as that work progressed and was moved into the ministry, went on to work with the CMA, eventually the Ontario Medical Association as a chief medical information officer there, and then their subsidiary Ontario MD as their chief medical officer. And after almost a decade there, decided to switch out into a broader space of consulting. So through Accenture into TELUS Healthcare and now at KPMG. And I get to work on the intersection between physician delivery of care and nurses and many other allied health professionals and digital health and digitization of what we do. And then the world of quality and policy and change, which for me is a really interesting triad. And I love that sweet spot in between. So it wasn't intentional. It's happened by, I guess, a series of small incremental changes in my life. And there were some changes that came along. I had children. I stepped back a lot from this kind of world and only did health medicine. As they got older, I got more free time. There were, again, opportunities like an election cycle at the CMA. I ran for president, didn't get elected. But having said that, learned so much about that process and the leadership qualities are required on the national stage that it was like an undeniable, exciting event and time for me. So lots and lots of interesting stories, but, I won't bore you with details of that, just to say the shortest path from A to B is never a straight line. And people say, how did you know you're going to get to where you are? And I always tell them, I had no idea. I still don't have any real idea. And I'm not done yet. My age is getting along, and I'm no longer in my 20s and 30s, although sometimes I think I am. But what that brings with me is, I think, a fair bit of experience and quite a bit of knowledge and common sense where I can compare where we're going now to things that have worked in the past, things that may not have worked in the past, and then provide good advice, which is exactly what happens in the world of family medicine and in the world of consulting. So it's been a really fun journey, and I'm excited to not be done yet. I'm excited to be moving forward still for hopefully quite a few more years.
Oh, absolutely. And thank you for that, Darren. There's so much to unpack there. Like as you were going, I was just nodding along. So I'll just
Yeah.
share some of my thoughts and then kind of carry us through. So when you first stated how you wanted to go into oncology, as you know, you probably recall when we first met, I told you I was doing my master's in physiotherapy. So originally I'd set out to be a clinician. So for those of you that don't know, physiotherapy, at least in Canada, is a 2 years master's program. So I was at U of T completing my master's and I got injured. And so I couldn't complete my program, but I was also gunning for oncology. I actually did my placement at Princess Margaret, a very well-known cancer center nationally, internationally. So the same thought as you, I wanted to be in that space to help. I also have a family with a history of, cancer and wanted to be able to contribute that way. But I do agree, even with those placements, it takes a lot. It takes a lot of you as an individual. I would come home and sometimes I would just look at my dinner like I couldn't because you're trying to process all of that. And so one thing I learned, and I think you share that as well, is to be present, whether you're with the patient 30 minutes, an hour, 15 minutes, whatever it may be, you empathize, but you also have to be present where you provide them whatever your expertise is as a physio, whatever my expertise was in that moment, and then to the next patient so I can be fully present and provide them with the care that I could based on my expertise. So when you shared that, I was like, yep, I was on the same wavelength. That was the goal. When you said about family physician, I totally agree with you. I think when I was in my master's, I think outside of women's college, you also had a clinic of your own, if I'm not mistaken, where you closed that, right? And you told me like so many of your patients were so sad. And I can completely resonate with that because my family physician, I've had her since I was a child. And so she knows everything. I don't need to tell her my allergies, nothing. And so I think as a family physician, you do become part and parcel of a patient and their family's life and as they go through things, because you are that single consistent point of contact. I may see a dermatologist, I may see an oncologist, but you will be my main. So I think that's beautiful. And I completely agree because I felt that as well. And I remember us talking about this. Moving along to your journey where you said that you dabbled into things and you just tried it and keeping an open mind. I think so many people, we always think that when we see people that have reached, these accolades, that maybe it was just the plan. They knew what they were going to do. But I think it's beautiful to hear how you said that you were just open to things. You try things. You also shared that there were, some setbacks as well. You tried something, but you still learned. And I think so many of the times we think that, only failures happen to us. When you see everyone like on LinkedIn and everyone just killing it and you think, but, do they also go through things? So I think it's so beautiful. And I appreciate you being vulnerable and sharing that so others know that, hey, even along with those accolades, with successes come, some setbacks, and you learn from that. You keep moving forward. They didn't stop you. You continued. You've grown even more, and you're still not stopping. And I think that's beautiful. So I appreciate you sharing that because sometimes when we see people that have reached higher positions or are more seasoned, sometimes we think, did they ever, go through that? And I love that you shared that.
That is
so I
part of
think
the
it's
human condition. We just don't know what's in the background. Everybody who moves ahead in their career has areas where they think, that wasn't so great, or it was not good for me. It wasn't a good fit for whatever reason. I think what is required in all of this, as you touched on, is a fair bit of self-awareness to say, look, I may be down a path right now that seems awesome from the outside, but it's not fitting with me. And if it's not fitting with me, I need to know who I am. I need to know why it's not fitting with me, and then have enough bravery and courage to pivot. And that's really hard, especially I find in some of our younger generation professionals now coming out that have been very streamlined, and it's been hard to get into programs and it's been hard to get through, and they've always been gunners and they knew where they were going to go. It's incredibly difficult for them to sometimes step back and say, I don't know if this is right for me. And especially when you've invested so much time and energy into that outcome. And I mean, it is a different time now. It is fiercely competitive, and a certain amount of knowledge and thinking about what that future looks like is important for success. But on the other hand, when you get to your certain level of now, like having your craft or having your profession, things spread out again and become wide. So you are able to pivot within your profession. I'm not saying jump from being a doctor suddenly to being a teacher or a lawyer, but I'm thinking within medicine, if you're interested in the business side of it, there are opportunities. If you're into startups, you can do a million things. If you're actually into policy, God knows we need good policy to make this system work. So you can devise your craft and hone your craft in ways that I think were never possible before because there's just so many more opportunities now.
Yeah, no, that was amazing. I'm so glad you mentioned that because even for myself, I can, I'll use myself as an example. So my goal was to be a clinician. I wanted to be a physiotherapist. Like you said, things happen. And so to reflect as my journey, so this is dating years ago. So me as a patient, when it came to, because I had an injury, so I had my ultrasounds, my x-rays, my reports, my blood reports. So back then, I paid for the CDs, so the copies of my ultrasound, my x-ray, so I could go to my sports physician, I could go to my physiatrist. And so that's what kind of made me realize as a patient, I'm like, I have to carry this. But because my health literacy was, I would say, compared to a lay person, I would say would be high because I knew that. My sister, who is on the legal side, she's like, I wouldn't have known to ask for those things. So that's what brought me. And so I was like, okay, there is a gap there. And that's what brought me to health informatics. So even though I cannot, in this current state, be able to, serve as a clinician, there are other ways I can bring that knowledge, that passion. And that's where I found this space. And that's how I met you. That's how we're having this podcast. So like you said, sometimes life allows you and you just have to let it. But that self-reflection is so key. So I can completely resonate with that. So before I take you, I want to dabble into your experience in digital health as a physician. But before I do that, just for those that are listening, in your career in medicine, are there anything that you'd have done differently? And also, do you have any advice for those that are looking to enter medicine or are just starting out their journey as a physician? Any thoughts or any pieces of wisdom there that you would like to share?
Yeah, I've got to say one thing I would do differently is I would have slowed down. It's interesting because where I went to school in Alberta, we had the opportunity to do a 3-year bachelor's degree, which I did. I went to Calgary, which because of no summer holidays has a 3-year medicine program. I graduated from medicine at the age of 23, which is pretty young. A lot of my friends were doing summers in Banff and traveling the world, and I put a lot of things on hold because I was on that path with a degree of speed that I didn't know how to slow down. Looking backwards and think even what I speak to my own children about their path, it's like, you know what, sometimes slowing down is good because it gives you more opportunity to experience and see what's around you. You make better choices up front if you're not constantly in a rush. And I think that would be the one thing I would change. I would have taken more time in my undergrad, and I probably would have taken more time in my medicine program as well because of the fact that we didn't have summer holidays. And at the age of 21, when all your friends are kiteboarding and climbing mountains and you're in the library, it was pretty tough. So, that builds a certain amount of resilience as well, but I'm not sure it was necessarily the best resilience for me, knowing now that graduating at 23 versus 25 or 26 in the lifespan of your career means nothing, but you don't get those years back again. Beyond that, I think I haven't had any regrets at all about the path I've chosen because I think probably family medicine was always what I was destined to be because it could be broad and I could still do procedures. I still did emerge. I did deliveries for some years early in my career. I worked hospital care. It gave me a huge perspective on the entire healthcare system. So I actually think that as my career has expanded into the world of digital and now, teaching both the Department of Family and Community Medicine at U of T, but also in the Institute for Health Policy Management and Evaluation programs that you've been attached to, and a little bit at Rotman in the school of business as well. That knowledge of the broader healthcare system from the view of family physicians is incredibly valuable. So although we don't necessarily go really deep into every area, we go incredibly broadly. So we're able to see things and observe things and have ideas about them. It's with a knowledge base that isn't superbly or supremely focused in only one little area of healthcare. And I think that's been good for me. I don't think you need to do that. You don't have to be a generalist to be a good leader in medicine. God knows we have lots of neurosurgeon leaders and cardiovasculars and respirologists who are doing great things. But I think it makes it a little easier for those of us who are generalists because we do see the broad system from every angle, including the patient angle, as we advocate for them every single day for some of the most basic services. So that's not something I would change. It's something I lucked into in a way because of making a change. And now again, one says, what would you do differently because of the pandemic? What would you do differently because of your age and stage? Like you, I had an accident 13 years ago now, which caused me to stop everything. And this was a sports accident. I fractured my spine in 2 places and it really laid me low for a series of months. But during that time, I had a really gifted mentor of mine, Mamta Gautam, who does a lot of work in physician coaching and leadership as a psychiatrist who has, in her practice for a while, has only looked after physicians. He said to me one day, 6 weeks after I'd broken my back and was basically stopped, Darren, this is your opportunity now. This is your moment where you can actually sit back and think, because you're forced to. You have no option but to sit back and think. So this may have been your gift to pivot. And that is the time that I pivoted. I moved gradually over a year out of my practice and gave it to a younger colleague. I went into the OMA, took a big leap into that space full time, and then started working more heavily in the world of policy and digital health. So, would I have not jumped off that cliff and fractured my spine that day? Absolutely, I would take that day back if I could, because of all the other things that happened as a result of those kind of injuries. Having said that, it did change things. It did give me an opportunity to refocus and pivot and to make some concrete decisions I think that I was ready for. I just didn't really know I was ready for yet.
Yeah. Oh, that is so beautiful. No, like the piece where you said at the beginning, where to slow down in life with technology, it's always just go, go, go.
Mm-hmm.
Like you're always in survival mode. You do, you just don't stop to be present. You know how they say, smell the flowers. Just even our careers, it's like we reach, this goal that we set, whether it was to finish school, whether it was, physiotherapy, whether it was medicine. But then it's like on to the next, okay, now I need my residency. Now I need a full-time job, right? So I think that's beautiful that to just slow down. In life, there's so much happening. When you can just ground yourself and be present, you can enjoy those and then just keep moving forward. So I think that's amazing.
It has to be intentional.
It's easy to say, I'm just saying it, but
exactly. Yes, has to be a choice.
No, I agree. And like the piece, I am so happy you shared about your injury too. Like you said, like when people ask me if I could go back those years and remove that day where I had that injury happen, yes, because like you said, there are other to your own body, like those trips to the physiatrist, the x-ray, all of that takes a toll on you. But like you said, it gave me time. I had to slow down. There was no, I kept pushing myself, and then there came to a point where I couldn't. And like you said, that's that time where I had to self-reflect, and that's where it brought me here. Would I have come this route if I had just gone through physio, became a physiotherapist? Would I have changed? I don't know. And like to your point, so sometimes life kind of just brings you there, and it's there to allow you to self-reflect and make the decision you want. We could have just kind of slumped and been angry and bitter. And I won't lie, there was a point of time where I was very angry because I was young. I had worked my way into getting to that program, and it is very competitive. But then sometimes you're like, okay, this has happened. I can't change it. So now what do I do? How do I use this so another patient doesn't go through what I went through and all that, right? So I think that is so true.
Yeah, and
like
if you're not, I don't wish a life trauma on anybody to try to
Yeah.
make those changes. So if that doesn't happen to you, then I think the only way you can get that perspective is through sort of contemplation and intentionally thinking through scenarios. And that just takes time. And you can do this incrementally. It doesn't have to be the big bang all the time. But you're right, in technology, the issue with tech is it moves so quickly. Simply keeping up is life's work. And never mind trying new things or experimenting, you do end up having to focus at certain points, though, to say, look, now I got to really dive in here because I need to learn this craft really well. And I still say this to my residents, look, I know you've got a health IT innovation startup going. I know you want to be a consultant. I know you want to do all these amazing things. But right now in your med school and your residency, your first job is learn to be a good doctor. This is why you're here. If you're not a good doctor, I'm going to tell you, no one will trust you in all those spaces you want to go to later as a physician. So please learn your craft today. Spend the time and energy it takes to get that done well. And then you've still got time to expand out in your 40 or 45-year career. There's lots of time to do all the things you want to do and more.
Yeah, no, I agree. I think we always have this time clock, like, okay, by the age of 30, I need to do X, Y, and Z. And then by the age of 40, it's going to be this. And then by the age of 50, like, we have these timelines that we put. But like you said, I think you have to engross yourself in your craft. Anyone, whether it's medicine, if you take somebody in the arts, a painter, anyone, if they haven't honed in on their craft, there will be the other opportunities will not be as solid because you don't have your foundation. So I think that I agree with that point. That is so key. And kind of dabbling into the technology piece that you mentioned, let's kind of make it into a segue with digital health. As a family physician, in your practice from the get-go over the years, I know we spoke about this, that when you started your career, it was paper-based. So for those of you that aren't aware of it, back in the day, all the documentation our physicians did, referrals, everything was handwritten. They had files. My optometrist, he's a gentleman who's going to be retired soon. He's like, I'm not doing electronic. He still has all his files. He has my files since I was little. And he has it all paper-based, and that's how they did it. And he keeps track. There is no confusion. He knows when I was seen last. He knows when my, vision changed, X, Y, and Z. So they're very efficient, but, things change. And I know, Darren, you mentioned that you were part of that transition where from paper-based, it became electronic. So in your practice, even now, so you were in the hospital base, you had your own clinic in the community. what tools do you use as a family physician starting from then, and the, the involvement that you've seen, and then just building off of that, in addition to those tools, because you've gone through so much change management, in your opinion, what allows for that successful adoption and
Yeah.
clinician engagement? Because I will say that's some of the biggest things, some of the biggest hurdles that we see. So I know it's
Yeah.
twofold, so I'll let you kind of carry us through that. But yeah,
Sure.
please take it
But they
away.
are connected. I mean, I've been super lucky in my career path from my very first days in practice to be in practices with other doctors who were fairly forward thinking. They were fairly innovative. They always wanted to be on. I always talk about leading edge, not bleeding edge. So, you don't want to just bring the first thing that's out there just for the sake of doing it, because it might be a disaster. You do want to start adopting things as they come along when they're really practical and useful and have been a little bit pressure tested. So even way back in rural Alberta, where I was just out of medical school and residency, working for a couple of years in a small town, my group of physicians, we had one of the first computers. We actually celebrated when we hit 1 gigabyte of storage on our hard drive. Like, that was a big upgrade. So, I mean, we were very early on. In those days, you used the computer mostly to just kind of read things. It was like digital textbooks and things like that. Very early on, we got into computerized scheduling, and I think incrementally, you're able to bring more and more in. My real push into digital health was when we adopted our EMR in my clinic in Thornhill, and this was in 2007. So we're talking quite a while ago now. We weren't the earliest adopter, but we were early enough, or actually luckily enough, went live at about the time that the program for adoption in Ontario was really taking off, and Ontario MD existed, and Canada Health Infoway was sponsoring a peer leader program across the country in various jurisdictions. And I was asked if I would consider applying, because our adoption had gone really well in my practice. Only through like really obsessive project management, I have to say. We went from looking at a product to going live in less than 3 months. We had our entire staff engaged and involved on this. We tried to make it fun. We made it inclusive. We wanted to ensure that everybody was trained to the optimum capability of that EMR. We want to make sure that everybody kept being trained every time there was an update. We had a new trainer in. We're trying to stay on top of the software so that we used it to its ultimate effectiveness. And I think that was also intentional. And it took a lot, speaking of how do you make this work, it took a lot of handholding to a degree with colleagues who may not be quite as convinced as you are. It took a change champion. In that case, that was me and one of my nurses, to really push this forward and say, look, we're going to help you through this. We're going to be here with you. We're going to take a lot of the burden on our shoulders of the administrative work and the setup and the networking, et cetera. We're going to hire out what we need to, and we're going to invest in this. This is not a cost to our practice. This is an investment in our practice, because we could see the streamlining of many processes that came from that. And I think one of the most important things about the digitization of health, which makes it really important for us now in medicine, more so maybe than say the optometrist, is that the complexity of what we're seeing is so dramatically greater than it was even 10 or 15 years ago, that we just can't keep track of that stuff on paper. It's physically impossible. Maybe for a single, like if you had a very narrow specialty, you might be able to, ophthalmology, optometry, let's say, but even then there's so much more now that's coming along. It's gonna be really hard to do that. The big thing is you can record, and I mean, there are still some jurisdictions. I've been working in PEI for the last year with KPMG on their primary care transformation. They've gone live with a provincial electronic medical record now, one instance for the entire province, and they largely went from paper to that EMR. So there were parts of the country, and still are, and lots of physicians that are still using paper because it works for them. Having said that, if you need a data-driven healthcare system, if you need to be able to do analytics that tell us where our energy, our effort, our finances should be put, we need these systems to be electronified, essentially. Now, that does fall on the back of clinicians to do a lot of the work of inputting of data up front. And I say to a lot of doctors who go, I don't have the time and energy, which is truly a reality right now, as many people are pushed to the limit because of the demands of patient care. I try to say, look, again, it doesn't have to be big bang. You can do this incrementally. You can actually take it on at a pace that you feel comfortable with. I want to make this interesting for you so it doesn't necessarily feel like work. It might be more time. What I found, for instance, going into my digitization, going from paper to an EMR, where I was actually looking after patients that had been in that practice, in some cases for over 50 years, because it had been around since the 1950s. is I found incredibly interesting things about those people that I didn't know, or I might have missed, or upgraded my knowledge about what needed to happen for them, because it simply forced me to look at their chart as I inputted their data into the EMR. So we viewed it as a quality improvement project. We said, we got to get most of our charts in by a year, almost all of them. Within 6 months, we're probably going to have that 80-20 rule. The 80% of your practice 20% of your practice takes up 80% of your time. All has to be there because that's your day-to-day workflow. And I got to tell you, we were still pulling charts we didn't go back forever with our data input. We just put the important profile items in. We would pull charts from paper when we needed it. After less than 1 year, mostly we stopped pulling charts except for the annual physicals, for instance. After about 17 months, our charts went into storage. We found we just didn't need them anymore because we had done such a good job of inputting the data. And a lot of what you're doing with patients is within the last year's worth of information anyways. So as long as we had some of the important landmarks like dates of mammograms and pap smears and stuff intact, we could carry on without the original chart and just have it available when we needed it. But it was a progressive kind of program. And I think what some clinics don't do well when they're bringing in electronification is think through that process. Think through how people will be able to handle it, not just the doctors. Like we're talking the people using the EMR most actually are clerical staff. They're in front of that EMR every single day, every moment of every day, whether they're taking bookings, phone calls, etc. They need to be able to be fully up to date on this as much as I do. My interaction with the EMR is sort of 2 minutes at the end of my encounter and a little bit of looking during the encounter, but not so much every moment. So we have to consider every user of that. And my perspective in my clinic was every single person in this clinic needs to know every function of the EMR, at least superficially, even if they're not using it all the time, because in the case of someone being sick or we have some kind of meltdown or heaven knows what happens, everybody needs to be able to problem solve on how to make it better. And that was an incredibly, I think, successful program for us. That's how I got into the world of peer leadership, into Ontario MD and into that larger space. Not because I took a computer science degree, I didn't. Not because I'm a superstar. I like my Mac because I can turn it on and it just works. But because I understand how humans would use these systems and where they wouldn't. And when they won't, your program, whatever it is you're doing, can only move as fast as the slowest moving member of your team. We've got to make room for those people to stay up and catch up, but not make it painful for them. It needs to be good for them. So I think there's a bit of nuance in how to do that. That does take actually leadership skills. Every project needs strong clinical champions. They don't have to be doctors or nurses. They could be anyone who's going to use this EMR clinically and knows how to talk to people. But you need to have that change process going forward to allow it to be completed. And you have to understand too, and it means going back and looking where it's not going well, because things will stall. Human nature is like you get just proficient enough and you move on to something else. So going back and having a look again, which is why we brought every time we had an update in our electronic record, we would bring a trainer out again for a half day and say, show us everything. Show us everything we don't know. Show us what we need to know now in the new update. Let's just learn it. Did that cost us $1,000? It did. Was it worth it? Absolutely. Absolutely. And there's just no way you can get around that ongoing training part and still keep moving forward. So again, a brief snapshot of how I got into the digital health space, but mostly through our own electronic record and understanding how humans are using these. And that's still how I approach it going forward in my conversations around AI and my conversations around automation. And we also have to understand what part of what we do shouldn't be digitized, because I see some of the processes getting in the way of good patient care now. The computer is a blockade to communications. Sometimes virtual care has been that. I've had people say on either side, I'll never do a virtual visit and I will only do virtual visits. Like, no, that's not what patients need. We have to think about what we're doing and the impact it has on the people we're serving. So I think that's why we're there, right? And we should ask them. We don't do that often enough either. So asking our patients the impact on them when we make a change is super important.
No, oh my God, there's so much there, Darren. I was making like mental notes. I'm like, okay, gotta hit all this. But yeah, no, I think all of that you mentioned is so valid. The piece, even the example I gave of my optometrist being paper-based, like you said, he's a specific area, but there may be hurdles too. Maybe he needs to refer a patient. He's an optometrist, so he can check, but there's like an ophthalmologist, like you said, he would need to refer. And so, being it all paper-based, there are some barriers there. But to your point, right, he is a seasoned gentleman. He's going to be retired soon. And he told me, I asked him to, because I'm in this field and I've had him since I was like young. Yeah. And he told me, he's like, I'm going to retire soon, Fahreen. He's like, it doesn't make sense for me. He's like, I'm going to wrap up my patients, and then I will probably transition them to, somebody else or refer them. But that's me. And he's like, that's how I've done it my whole career.
And it's an investment in time and energy and effort. And at the end of your career, I don't think it's worth that investment. Yeah, although now we do have an argument in medicine anyways, that if you want someone to take over your practice, they will not look at it if it's paper-based. So an investment in offloading your practice or potentially selling it later may still be worthwhile in late career.
So that's a valid point too, because that's what I was thinking too. I'm like, okay, you'll transition. Like even me, I've been with him since I was little, but like once he retires, it'll have to be a clean slate, because they won't have my paper file unless they move into the same clinic or however he does it. So that's a valid point too, that sometimes we don't consider. So I think that's so important. And then the piece where you said about the change management, how you have like clinical champions, like me on the vendor side, when I'm training, understanding your workflows, like you said, there may be a physician that is extremely seasoned. And so when it comes to their efficiency in providing clinical care, they're efficient, they're quick. Yeah. And someone who's maybe a medical student or a resident, they'll be slower in that because they're learning. It's natural. But when you introduce technology and now you're evaluating metrics where you're like, oh, Dr. John Smith is, his time is a little bit slower than Dr. Jane Doe. But we're forgetting the piece that even though Dr. John Smith is a more seasoned physician, his, the rate at which he provides clinical care is more efficient because we're introducing technology. Dr. Jane Doe may be just faster at finishing her documentation or have you. So we have to be cognizant of that too. I've learned that as well with implementations. You do not want to upset or cross boundaries with clinicians that are seasoned, and it's not because they're not providing clinical care in a timely and effective manner. So there's that piece too. So I love that you highlighted that. That is very key as well, that we need to be cognizant when we're implementing that, about, clinicians that are seasoned and do provide efficient care very quickly, but it's when we're introducing technology. And you may, like you said, sometimes you just need to take a bit more time to go through some of the technological pieces so that they are comfortable. In terms of both, administrative staff and clinical staff, when I train my clients, I make sure I split my screen for both my coordinators, so my my administrative staff and clinical, and I tell them, I am showing you both workflows so you can help each other on the floor, because things happen. I tell people, I can say providers are only going to do this and administrative staff are only going to do this. I'm not there on the floor. I do not know what will happen, and you will come into hurdles that you will need to help each other. And when I'm doing office hours, I will say up front, administrative staff usually are the ones with the most questions, because they're the ones all interacting with so many patients. They're the ones doing their scheduling. They're the ones doing billing. Right? So you are so correct in that. And that's why I do it intentionally. I tell them too, I'm doing this intentionally. Others don't agree with me, but I still do it. Yeah. But, I love that you kind of follow along in those pieces as well. The last piece I want to dabble into, and I'm going to take that more into primary care, because I do want to dabble into that. So the piece where you said that it's so important to have this data, electronic, and the reason it's so important is to share that data. I know interoperability, there are certain barriers to that, but that data needs to be collected electronically. So whether it's the patient carrying their data along with me, so instead of me having my, CDs with my x-rays and my reports, I had a whole file. That data needs to be there. That helps prevent duplication of tests. That helps, if you have allergies, there's so much. So I think that electronic data is important. We're ways away from interoperability, but we need to have that awareness in those conversations to start us off with. So I just wanted to highlight that, because there was so much to unpack there, Darren. So I hope hit all the points, but but building off of that, when you're talking about primary care and how you, through that, this is how you got into the space, kind of going into that conversation a bit more, focusing on Ontario, where we do have a shortage of family physicians. And I know when you and I spoke about this last year, we had some conversations and you had some thoughts. And since then, there has been some changes where they're trying to loop in nurse practitioners. Mm-hmm. So for those of you on the call, so nurse practitioners, so under nursing, there is a huge umbrella, right? So you have your registered nurses, so they provide care, but your nurse practitioners are more seasoned. They go for more education. They have, other experiences that fall under that belt. And so they are able to prescribe, they're able to diagnose. There is a scope, there is an umbrella. So Darren, I'll kind of hand it over to you shortly to make sure I'm not miscommunicating, but my understanding, there are certain boundaries and what have you, but they are allowed to. And so just wanted to, in case anyone was confused about that, the difference between those two nuances. Now, that being said, in primary care, your thoughts of looping in nurse practitioners to help alleviate that. What are your thoughts on that? Is that a way to navigate that? Are there other ways we can still, address this gap of a shortage of family physicians? So I'll stop there, Darren. I'll hand it over to you to make sure I didn't miscommunicate the nurse practitioner portion, if you can kind of dabble into that. And then your thoughts on how is this an approach that we should continue with, or are there other things that we can still do to help this? So yeah, please go away. Go
Yeah, I
ahead.
mean, and this is topical just this past couple of weeks because Minister Holland federally has stated that each province will allow nurse practitioners to bill the healthcare system just like physicians can, and some other health professionals like optometrists, et cetera. They're going to have the ability to work independently in practices if they want to, or even better, in a team-based way, in kind of collaborative practices with a variety of team members, but they will be treated under healthcare billing rules very similar to physicians. I've been privileged to be able to, since my very first days of work in 1991, I've worked with nurse practitioners. I actually started my career in community health centers with nurse practitioners beside me. So I've always understood, the incredibly effective job they do on looking after patients, and how incredibly, I think, strong they are especially in the world of primary care. But now we also have nurse practitioners who are specialized. I see them now in emergency departments and operating rooms and cancer care environments. So just like in medicine, the scope of nurse practitioners has expanded as they've gone into specialty areas. And I think that's awesome. Governments are using a lot of sound bites right now to try to tell us what will be the saving of the healthcare system. And one of the most recent things will have been other allied health professionals like nurse practitioners, pharmacists expanding their scope of practice and being able to care for patients directly. In Ontario, Alberta, one other province, we have pharmacists that can prescribe and see patients around a series of disorders that they're capable of looking after independently. It's interesting because each one of those operating as a silo, in my opinion, will actually do very little to solve our crisis of access in healthcare because they are siloed. And I think then these are stopgap measures. It's kind of like, there's water springing out of a dam, and you're putting a finger in here and a finger in there to try to stop the flow. But eventually the dam's going to break if you don't actually buoy it up and rebuild that dam in a way that's strong. And we do know through lots and lots and lots of academic and practice-based literature in other countries, plus our own, that collaborative team-based care is the reconstructing of that dam that will allow that strength to occur if we assume the primary care will remain the cornerstone of our healthcare system. There are some systems that don't have that. If you're in France, or if you're in many cases in the US, you don't have a family doctor. You've got a cardiologist, a dermatologist, a gynecologist, a gastroenterologist. You've got a list of 10 specialists, none of whom talk to each other or really want to know what the other one is doing, which leads to all kinds of trouble with interactions and side effects and the wrong thing being done, in some cases, errors that are significant. In Canada and places like the UK, Australia, New Zealand, we have been able to have primary care as basically the building block of our healthcare system. So not just that we should be the gatekeeper to the healthcare, I think that's gone way too far, but that we are actually cornerstones and we're the foundation. So people have a medical home they can come to that trusts them. This is the old-fashioned family doctor office in the past. Now it's a newfangled primary care team with multiple healthcare providers in it, where the idea is the best person for that problem that's available that day for that patient, fitting the scope of their practice, is offered to that patient to look after them now. And we do it in a way that we communicate what's going on. The patient has a very solid record that everyone can see. The data follows them between providers. There is, especially for complex and chronic patients, there is a team-based approach, meaning I need my dietitian to interact here on this schedule. I need my physical therapist. I need the nurse practitioner. In terms of NPs replacing doctors, I'm absolutely not worried about that. I don't see them in any way as a competition. I see them as, equally important members of a healthcare team that can really help me do my work better if I know how to incorporate them well into my practice. And it's not as though that they're going to be significantly cheaper or significantly more of them. I always say, nurse practitioners are not dropping out of the sky looking for work. There aren't enough of them either. So, we've got to really figure out how to integrate that type of care with their scope of practice into a medicine style with its scope of practice, plus also pharmacists, PSWs, social workers, the various healthcare providers that can form a primary care team. So the patient is looked after globally. I think the idea of one patient, one doctor is antiquated. I think, the world has changed. We become far more complex as patients. Medicine is far more complex. I don't claim to know everything there is to know about the very important effects of diet or exercise in a really deep way on my patient's health. I know quite a bit, but I don't know as much as a dietitian would. So I need their experience to help out in this patient care and make me smarter too, because everything that happens with that experience comes back and I get to learn more and understand that. So in my mind, I do not see the NP expansion as a threat in any way. Let them below hip for sure. The one nice thing that's doing, I think, is decreasing the very weird now dichotomy of private nurse practitioner-led clinics where your visit might be $250, which you're paying for cash because they weren't able to bill, where a family medicine clinic is not able to do that. They must bill the healthcare system in Ontario anyways. And so we're going to see an equalization of the playing field as nurse practitioners are going to be billing, HIP just as I am. And I think that's okay. Like, I think there's enough work to go around. We're not worried about that, and patients our population is growing. We're aging. There are lots of physicians who are timing out in terms of their career path, or they're choosing half-time work or alternate scope of practice. We have lots more women in practice that if they choose to have families, significantly reduce their practice time earlier or midpoint of their career and then ramp it up again later for so many good reasons. So the idea is we have to be able to flex and bend to all of that. And I think it isn't fair to say those people, that type of practice should not be allowed to work independently when they have super good skills. And I got to say, there's probably 80% of my day-to-day work I do as a family doctor, the nurse practitioner can do absolutely just as well. Some cases even a little bit better. There are aspects of my training that have gone beyond what theirs have been. And what I loved in the environment I worked in at women's college, for instance, for a decade, is I frequently had the NP knock on my door saying, can you come and have a look at this with me? And I loved doing the same thing back. They had skills like they put in way more IUDs than I did. If I was having trouble, I'd be like, can you come and help me? And they would. That's what team-based care is about, right? The right skill set, helping each other out, making the patient win, basically. Let's do it.
Yeah, no, absolutely. And I thought it was so beautiful where you said about, having a primary care team and how you mentioned, like, in addition to a physician, a nurse practitioner, a dietitian, physiotherapist as well, right? I remember speaking to a physician where I think it was like, there's only a certain amount of time or a module that you do in muscles and what have you in rehabilitation, unless you're a physiatrist and you'll specialize. So that's where a physiotherapist could kind of help with that, right? When you said about exercise, you may know some, but that is our expertise. So we would be able to help navigate that. So like you said, each respective clinician has their expertise that they could bring to the table. Just need to be in a collective environment to allow that. And just to make sure I understood where you said, like, where pharmacists are, their scope has been expanded as well. And now nurse practitioners, and where you said that it's kind of like a dam where you're just covering holes. So what you're proposing is to have a health team where they are in a same environment, so that way you can, tap into one another. That's what you meant, right? Instead of just kind of having individual, like, pharmacists in their community pharmacies and nurse practitioners in their own clinics, you're suggesting to allow that, expansion in scope, but to have an environment or a clinic where everyone is together so you can tap into one another based on what the need of the patient is. Is that what you meant? I just wanted to make sure I understood that.
You don't have to be physically together all the time. There are ways to do team-based care that is collaborative in a greater community. So often you'll have a clinic, and there may not be enough work to have a full-time pharmacist there. Like, if you have a smaller practice, you just don't need a full-time pharmacist all the time. So maybe what you need is a community-based pharmacist that also works as your collaborator, patient educator, et cetera, that is not physically located with you, but is linked in with you, so they can see the record, they can share data with you, you can pick up the phone and call them anytime. And actually, realistically, this is what many of us have in our communities anyways. We have, even where I was working in Thornhill for 21 years, I had my pharmacist on speed dial that I could call anytime, say, can you help me with this? I have a question. You know this better than me. Help me out. And they would drop everything and have this conversation. And I would do the same thing back for them. So I think in smaller communities, we're really used to this. In small towns, everybody involved in healthcare is the team. We're talking the parish nurse at the church or the faith-based organization helpers. We're talking the Meals on Wheels delivery drivers. We're talking nurses in the community and public health, the doctors, the nurses, the hospital. It is all one team because there are only a few of you looking after that entire population. Now, in big cities, we have the luxury of being able to, I guess, parse things out a bit more. But when I say putting fingers in the dam, it's basically if you just say to all pharmacists, like, please go and see all the people with colds or urinary tract infections. And they do it by themselves. They never tell me what they did. I don't have a record. I don't see what's going on. That doesn't help the patient,
It's
except
siloed.
for convenience. Yeah.
Yeah.
Convenience is a thing. I get it, but it doesn't help the overall care of that patient. And I think what I need to know is, hey, maybe at night, if I'm not available, one of my responses to my patient is, can you please go see this pharmacist in the community, because I know they do their job well and they're going to report back to me on what they've done, and it's going to be a collaborative effort. It doesn't have to be co-located. And there are lots of places where co-location makes sense, especially if a large enough practice and you have the place to do it. But I've been spending a lot of my time in PEI in the last year with my consulting work at KPMG. And what I know is in some of the very small towns, co-location is just not practical. You don't have enough of the population or demand for some of these allied health professionals to be in one spot all the time, servicing only a very small community. They're going to need to share between practices, which is fine. So that becomes a home and then a larger network around it that basically accomplishes that sense of team, whether or not it's all in one building or some co-location and some virtual, or some movement of healthcare practitioners between the clinics over the course of a few days. You can do it any way it meets the needs of your community, but the concept around team is real regardless of how you're sitting down with each other every single day in front of each other in the same building.
Got it. No, okay, that helps. Yeah, so that I completely agree with that, right? Like you said, so if I do see my pharmacist, that you have that communication that, okay, Fahreen saw pharmacist like for a cold, prescribed her this, or, just gave her, off the counter Tylenol or what have you, right? So yeah, that I think that is so valid and so important, right? We talk about that data. If we keep it in silos, it serves nobody. It needs to make that circle around, so the people that need to make an informed decision about that patient have that data. I could be allergic to certain things, right? That too, that needs to be circulated, because we've seen adverse reactions and all of that. So I think that piece is so valid.
Yeah, and if we're gonna approach burnout in a very real way, we're gonna have to learn how to share a bit better. So
Yeah.
it isn't that everything always has to come to me. Like, what would it be like to have a pharmacist on call at night when a patient calls with a medication side effect and gets the pharmacist directly? That would be awesome. If that pharmacist says, look, this isn't actually medication side effect, this is an allergy, we now need to speak to the NP or the doctor to deal with that medically. Absolutely. That's exactly what should happen. So, but it is actually an important thing to say, people need a team, like professionals need a team around them as well to feel supported, to reduce burnout, to spread the base of work around more equitably, and then to ensure that, especially in complex chronic disease, the right person is dealing with that problem at the right time. And that improves access, it improves reliability, it improves trust. It allows people to work to their full scope of practice in whatever profession they're in. And it builds that sort of network, neighborhood, kind of family idea that we all want to belong to as patients. It makes us feel at home, right? And we build a relationship that way. So I think that's really important and can be done as easily in a large city as it can be done in a small town or a remote territory in Northern Canada.
No, and I think that's so valid. So building off of that, towards the end where you said, like, don't see it as a concern, like expanding it to nurse practitioners, there's enough work to go around. There was a comment that I saw on LinkedIn that a physician had put, and just wanted to get your thoughts on that if you're open to it, where he had said, if if the payment or, the rate for that is the same, whether I'm a physician or a nurse practitioner, he's like, what is the incentive for me to go, and complete medical school, which is X amount of years, X amount of debt, X amount of residency, as opposed to a nurse practitioner, which is maybe in comparison, maybe less amount of debt, less amount of time. And if I'm going to be paid the same. Do you have any thoughts on that piece? Or is there additional information or context that needs to be known to understand why that is, or why that actually may not be? Any thoughts on that?
Yeah, I mean, we don't even know what the payment model is going to look like yet. So
Okay.
no one's really seen that in any of the provinces that I know of, maybe a bit earlier in BC than we are in Ontario. But even then, we don't know exactly, and it comes down to two things in my mind. What does equal pay for equal work look like? Okay, so if you're being seen for a urinary tract infection, it is a pretty simple, visit and pretty simple set of diagnoses, and multiple different people would know how to do that. That makes sense to me, to have a payment model that is probably equal amongst practitioners. Then there's a sense of sometimes expertise is required that comes with longer years of education or more years of practice. Having said that, I know some pharmacists in practice that have got, pharmacy doctorates. They've been educated longer in the university system than I have, frankly. in different things, but I have skills that they don't have, and they have skills that I don't have. So my point would be, look, maybe what we're going to be looking at is a differential fee schedule that might be similar to why a specialist in cardiology might be paid more than a family doctor would on a yearly basis, more specialty, more insight, more knowledge. But there is a degree of equal pay for equal work. And there's also an aspect of gender pay equity that I think we don't talk about enough, but some provinces are starting to approach. I look at the new physician services contract in Saskatchewan, where I was working in Saskatchewan with KPMG on their primary care model a year ago. They specifically approach gender pay equity, which I think is important. And so these aren't going to be easy conversations to have. And what I resist is the constant temptation to come back to the dollars and cents of it, that we derive our worth and our value based on how we're paid. I don't think that's true. I don't think that's why we went into medicine. Like, you can choose to be a nurse practitioner or a doctor. I'm assuming you choose to do medicine because you actually love medicine. You love that science. You love that degree of depth. You love that degree of responsibility. You can choose to be a nurse practitioner because you love what nurse practitioners do. That's truly how we go into it. I've yet to meet a single medical student that said, I chose family medicine over nurse practitioners college or school, it's university after nursing into NP because I'm going to be paid more. No, I have never seen that. So I think then it's really about finding the work that you love. And I don't think that we as doctors have to be worried that some people are being paid on a level that's approaching ours if they're doing almost all the same work. Now, maybe there will be times that I'm going to be called upon to do something very specialized on a patient that is beyond the NP's scope of practice. One would argue that I might well want to be paid more for that because of the special expertise around that. Now, this is all going to depend on how we're paid over time. Fee for service allows you to make those specifications pretty easily. If we're salaried, which is where more and more provinces are going now, like in PEI, with their new physician services contract and patient medical home, about 75% of doctors will be salaried there, and employees of the agency, Health PEI. That's a very interesting way of doing things, because we don't have anything close to that in Ontario. But there will need to be a lot of attention paid, I think, to the concept of equity and not just equality, and I think that's going to take an analytic, but we can do that analysis. And we can prove the point that certain professions make certain amounts of money based on their blend of both the procedure and thing they're doing right then and there, their specialty qualifications, whatever that looks like, even as much as years in service, right? Like, there's something that comes with experience that we don't think about at all.
Yeah.
So, I mean, we probably need to think that through much more carefully. Whenever someone responds on social media with a question or a comment like that, I first want to ask them, what are you scared of?
Yeah.
And I don't know they always know what they're scared of. Sometimes we get these reactions that are incredibly, I think, volatile and vocal. And to me, it means somebody is feeling like they're being treated unfairly, or they're scared about something. If we can unpack that, if we can reduce the fear, or maybe show them, as I've worked side by side with an NP for so many years, how well that works, and I have no fear whatsoever of that, maybe there's something to be learned from that. So again, it becomes a conversation, education. We do have unions, we do have associations, we do have associations that are unions, etc. And they have very specific rhetoric based on what they're mandated to do, like negotiate for me. I get it, but we have to understand where all that comes from. And then I'm always wondering, if someone's really upset, let's find out why. Maybe there's something to it. Maybe we have to figure that out and consider it, because I think we don't have all the answers in this space. We're crafting it as we go. And all we can do is be honest about it.
Yeah. No, I think that's so true. When you said that, it kind of resonated with me in the sense of, with me, when I'm implementing various digital health tools with with a hospital, clinic, you name it. And when I get pushback, it's usually that there is a reason, like you said, if there's a clinician or administrative staff that they're not comfortable, there is a reason why they're resisting that change. Sometimes, it's human nature. You don't want change. I get that. But most of 99.9999% of the time, I have seen there is a reason. Like you said, they're uncomfortable. If I take the time to discuss it with them, whether it's one-on-one, away from other, team members, so they don't feel that pressure, they will highlight for me why. It is, I'm feeling overwhelmed, because, when we normally do the initial intake, we do X, Y, and Z. Now you're telling us to do this. Okay, so is there another team member can help do this task? You know what I mean? So to your point, I think
Absolutely.
when people do push back, there is a reason. Sometimes it may not, and be upfront about that, but there is usually a reason. And we need to, remove those layers and work through that to understand what that fear is, what the concern is, and then address it. So I think that's so beautiful the way you mentioned that in every aspect, you can apply that thought process to understand where you're getting that pushback. And the piece
And
where you said
sometimes we
about,
are just scared,
yeah,
and it's okay
yeah,
to be scared.
yeah,
And
exactly.
fear goes to a lack of understanding. So, I mean, if you can help a person understand what the reality is, it takes away a lot of the energy they're expending on resistance. And I think resistance to a degree is helpful if there's something there that really needs to be thought through.
Exactly.
But lots of our resistance now in healthcare is misdirected, and the energy could be better put elsewhere.
No, that's so valid as well. And so kind of building off the way you said about the compensation, salary, potentially being salaried and, all of that. So that piece in terms of figuring that out and kind of closing the loop with moving it to the patient side. So like you mentioned, having salaries, trying to understand all those pieces, that how you come up with X amount and, based on everyone's expertise. On the patient side, helping them understand that, okay, my pharmacist can help me do this. My nurse practitioner can help me do this. My physician is still for this. Because I know earlier, before we even started recording, where we spoke about on the patient side, for me growing up, my parents, my grandparents, it was doctor. You went to the doctor, something happened, and that's it. And so now, how do we educate? Like for us in the healthcare system, or, you name it, we may be able to understand that, yeah, like me, as a physiotherapist, I would go to them if I need X, Y, and Z. I'd go to a dietitian if I need X, Y, and Z. So how do we bridge that educational gap with our patients so we can help them navigate, get the help that they need, and they are comfortable that they're going to get that? And the reason I say this is, in the past, when I've taught other classes, we've had this conversation where I ask them, if you had the choice, to more easily access a nurse practitioner compared to a physician, a lot of them have that. They're not as comfortable because they think they may not get the same quality of care. And it's just that gap of knowledge. So from your perspective, how do we address that gap with our patients to empower them?
Yeah, I mean, you're right. It will take there's a literacy component to healthcare from the patient side that we actually frequently ignore completely. Digital literacy, we never ask patients if they have any sense of how to do a virtual visit well, or if they have any sense of how to properly email us their questions if we're going to use email. Like, we don't ask that, and we should be. There's always an educational component to making this work for everybody. So we're talking about the practitioners very clearly, but we have to educate a patient what a medical home actually looks like. And for me, this isn't about, this isn't
Okay.
just about people understanding what different job descriptions are or job types. It's more so letting them know that if they call this clinic with a problem, that they're going to be dealt with fairly quickly and quite effectively. And it may not always be only by a doctor. Sometimes the doctor has to be required. Sometimes the doctor is the person who's the most available that day. And they might even be asking to see something the nurse practitioner could handle it, but they're going to be seen by the doctor anyways. So what I've learned in team-based care, because now through women's college, I worked in the family health team for a decade. I saw that patients that were quite comfortable being able to see a practitioner that they knew the team endorsed generally. Like, if they're there and they believe this institution is as high quality, they have a sense of trust that everyone working in it is high quality. Again, we can't guarantee day by day we're always at our best, but generally speaking, our practitioners are excellent. And if you're there and you're being seen virtually or in person, and your worry is being dealt with by someone who you believe cares for you, who is listening to you, who will communicate for you and advocate for you, whatever problem is there, that's what we really want, especially in primary care. So, I mean, if you're going to be doing a skills-based thing, like you have to have a lump or bump removed, I definitely want to know the person who is doing that has done that before and understands how to do it. But the vast majority of what we do in primary care is conversational. 40% of my day is in the undifferentiated symptom complex. We don't even have a diagnosis yet. So we're actually trying to figure it out. And that might mean your first point of figuring it out is with a person who's not a doctor. And eventually you'll see a doctor. We don't know how that's going to go. It may also be that people come in to see me for their intestinal complaints, and the first thing I want them to do is sort out their eating habits. I'm going to send them directly to the dietitian. So, it can go both ways. And I think what patients want is to feel heard, to feel understood, and to be known. And you can be known by a group and a community, as well as known, probably actually better than known individual who's trying to manage, say, 2,400 patients constantly, or 1,400 patients constantly. So I think it is only a matter of time. Those people that have been embedded into a primary care team as a patient for a while get it
Yeah.
mostly, and
Yeah.
they've experienced it and they feel it and they endorse it. And
Right.
I think that's kind of what we'll have to do is just keep doing it in the right ways. The patients come to understand it. And can we train them a little bit? Sure. Handouts, videos, whatever it is we do, introductions, saying hello, telling
Yeah.
people, I'm going to see you today for your problem X. But we'll have you see your pharmacist tomorrow or your doctor a week from now. That's fine. People just need to know where they're going and have it explained to them.
Yeah. No, I think that's so valid because as you were explaining that, I kind of thought of myself. So my family physician, she has a clinic and then there's a pharmacy right across. And so whatever prescription she gets me, I go to him. So sometimes I'll even call him. I'll be like, I took X medication. Like I have this antibiotics. Can I take a Tylenol with it? I took it at this time. Will it react? Or, you name it. And so I think to your point, it's because I know he's my pharmacist. He's directly connected with my family physician's clinic. So I have no trouble. Instead of calling her, I can just call him and be like, hey, I got this prescription. You have it on file. I took it at lunch. Can I take this? So I think that's so true. Like with patients, like you have to walk them through it. It is new. And so if they're comfortable with you and you're like even the front desk staff, then they can help them be like, hey, today we have, the pharmacist who'll be able to help you out first. Or,
Yeah.
we want to say, so I think you're so valid there where you belong, you feel that you belong. Because I've been there. I know he's right across. I've seen them. And so even if I'm introduced to somebody else, I will be more open to it. So I think it's also taking patients along that journey. And I think when we're implementing new things, whether it's a workflow, whether it's a tool, along with our clinicians, our administrative staff, we cannot forget the patient journey and what it means to them. So I think that's beautiful that how you mentioned that.
It's
I'm
very
gonna,
true. And
yeah,
we do learn from each other, right? So we
yeah,
get smarter as a team. I think individually we get smarter when we work together as a team. And that means that my skill set expands. So even better from the patient perspective.
yeah, no, that's so true. So I'm going to take you to another avenue. So artificial intelligence, AI, we talked so much about it. And I know last time when we spoke, you had mentioned how you still think it's early for artificial intelligence to come into the healthcare space. So I want to open it up to you on those thoughts. And I know we just, kind of discussed how with AI scribes, right? So what we mean by that is, a physician or a clinician will have their session with their patients and the AI scribe will document the whole session and then help populate certain templates into their documentation. And because we've seen that a lot of burnout, like you even mentioned earlier on the call today or on our session today, rather, that documentation can lead to that burnout because you're saying X amount of patients, you still need to document. So what are ways to augment that? So that's one common piece I've seen. And I think a lot of clinicians, physicians, very open to that. But wanted to get your thoughts on that and also in general, your thoughts on why maybe it takes some time for AI to come in and in what scope would it come in? Yeah, so please take it
Absolutely.
away.
Yeah. I mean, AI scribes have been the lowest hanging fruit right now because number one, it's been a clinical need,
Yeah.
and charting is the bane of our existence. I mean, it just takes
Right.
forever, especially with complex patients. It's always at the end of your workday or like taking time away from other things like your family time, etc. So it's seen as a burden. The need for documentation medical legally has never been greater. And from the communication perspective in a team-based environment, especially, it's always super important. So scribes are low-hanging fruit made possible by large language models, made possible essentially mostly by ChatGPT because a lot of the LLMs, a lot of the scribes are using GPT in the background for their processing. So I mean, that is to me that's a no-brainer right now, and the results have been fantastic for docs using this robustly. And we've been hearing through the Ontario MD study, for instance, up to or maybe in some cases more than 2 hours per day of reduction in your charting time and very high quality notes, super high quality notes, probably higher quality than I can do at 11 o'clock at night when my eyes are half shut and I'm drifting away. So I think it's an important piece. Now, what did that require? It requires a very, very large learning set, which is basically the English language and the context around how we think and speak. So language models have been not easy to develop. They took, a decade to really perfect, but now are really good. And if we're in a conversational kind of interaction with the patient, they work super well. So that's great. Now, if you start expanding AI into other areas, I kind of think there are two main areas in medicine that we're going to be looking at, maybe three if you count the larger system. The first is automation. So there are lots of things we do in our practices that are kind of ripe for robotization. So, the way that people book appointments, the move to online there, for instance, the repetitive things that we do in practice that will require an analytic, like let's looking at when flu shots are available, or when there are seasonal variations in visit timing. We can analyze that and then craft our processes internally to be more effective, not just more efficient, but more effective for those variations. Now, what is required for that to work well is a data set which is very specific to that practice, being compared to a larger data set which can be considered the normal and show variations, right, or where there's a variance. Now, what we don't have in many cases is a really robust data set in practice because of the narrative nature of what we chart. And so we don't have really great coded data there yet. And no doc or nurse wants to be a data coding monkey. Not happening. So we get huge resistance on that. But now what's interesting is the large language models and the natural language processing are bringing to the forefront the ability to code our EMRs really effectively. We've seen this most in the hospital space now. Companies like Semantic.ai, one of my previous students built this company, and he has done a great job of getting the system to read hospital charts and begin coding it. And they're coding it for the purposes in the hospital of billing, because that's how they receive their income. And the hospitals are willing to pay for it because they get they get a reimbursement on that based on better billing. And we don't have that same incentive in primary care or in the community. So we don't get a payback on that when we're just billing fee for a visit, like fee for service. So we don't have access to that same data set right now. There are no EMRs that put an LLM on top of it and do the auto coding in Canada. But in the US, there are. And in an accountable care organization where there's gain sharing and risk sharing, it's worth the investment to do that. So we see that kind of rounding the corner. The other thing is the large data sets compared to for health outcomes are starting to come together, but they're not yet mature. And what I really need is an awesome data set that reflects the population I'm working in and living in to allow me to do the comparators. And, our ministries of health are trying to build that. We have research groups trying to build it, and we'll get it. It's just not yet ready. So, I can't just throw a large-scale analytic automation tool into my practice, except for very basic functions like scheduling and perhaps handling telephone calls and things like that.
Yeah.
The really important world, I think, will be in clinical decision support, where we're going to be able to look deeply into populations of patients to say, hey, I find outliers here. This is like a rare disease grouping. There's a genetic issue here. There might be an outbreak of a communicable disease in a small pocket of my community. And that requires a lot more. It requires more data to do the background learning of that AI algorithm on. It requires a very robust, highly functional data set around my patient to throw into that mix and compare to many more concerns around privacy and security and data ownership and cross-border use, cross-border data flow, et cetera, that becomes political. And so again, we're going to get there, and it works best right now for very specific diseases that have a very, let's just say, linear pathway to the kind of care that we have to do. Like, let's say all the diabetics who have to have their blood work done in a schedule and their eyes examined in a schedule, and they're like, you can use AI now to try to find those people and ensure that process keeps going. Where it stops is usually because it's benign neglect. It's not because we don't know the right thing to do. It's just we don't get to it, or patients are reminded for it, or whatever these kinds of things. So we can do that kind of work with more AI tools now. But what I really I'm excited to see, which I think will come even in my career, is the ability to apply an individual patient's problems to a much larger group of unknowns right now to find signals. Let's say that's a series of genetic markers in their DNA that we now see a signal, hey, this genetic link might actually be a preponderance of disease coming forward in 5 years or 10 years, looking ahead on prediction and predictive modeling for individual patients and for populations. And, you were going to ask me in our pre-interview about population health. I think this is where it really starts to blend together. So population health is just predicted analytics applied to a large group of people, where you can start to find signals that you might want to act on a more global basis than you would for an individual. These are signals around things that happen at scale. So they could be disease markers. They could be preventative care aspects. They could well be outbreaks that we're not aware of because we're not seeing them in volume, but you can on a population level see that. And then you could apply dollars, resources, and people to move that like bell curve of normal along a lot further if you're doing it to a group as a whole than one by one by one by one by one. So I think AI is going to allow us to find those individuals and those groups much better. What we need in there, and I've written about this a bit in my blog posts over the last year, is like trust. We as practitioners and even patients don't yet have trust in these algorithms that what we're learning is applicable to them. Whenever I apply any kind of analytic to a practice, even if it's just a very basic, like quality improvement analytic, the first thing practitioners say to me is like, that's not my practice. That analytic doesn't reflect me. It doesn't reflect my patients, doesn't reflect my population. I'm like, well, you might actually be right. So let's find out why. Either sometimes there's problems in the data, we have to correct it, or there is a very real variation in that practice that we need to understand. Let's say you have a practice that's all young women having babies because you have a very high volume obstetrical practice in family medicine. Let's say you're doing addictions and like 80% of your population is addicted to a substance and they're on methadone or buprenorphine or some kind of like very niche practices. So, you have to be able to identify those to either include them in a new population to look at or exclude them from the general analytic because they're outliers. Population health works well for the demographic in that bell curve. And we can do a lot with that bell curve to affect significant disorders at scale without forgetting about the individual where I might have a very rare or specific or unusual thing happening to me. And the analytics running in the background using AI modeling might find me before I even know I have such a problem. And that's important too for early disease detection, prevention, and potentially treatment, right? So it's a big future world. But I think what we got to do is start where we are and use the products that are available to us now. Like, there's no reason we should all not be using scribes now. Like, they're good. They're really good. And they're not expensive. So, like, let's do it. And then what happens there is we move into the world of data cleanup and being able to make our EMRs perhaps more robust from the data perspective. That also is important, interoperability and data sharing. You can't just share random stuff that's not standardized and normalized. It improves the quality of our actual knowledge of our patients. It improves our ability to actually interact with them. We say, hey, I didn't remember this, but my system just told me that you were due for shot X and Y. You haven't had your mammo done. I see that you're in our genetic analysis of you. We are finding you might have a signal for a rare disease. I want to dive deeper into that testing over time, et cetera, et cetera. And we go on for hours. So it is coming fast. These models are getting so good so quickly. Language, obviously the first one we're looking at now, but lots of examples in acute care where predictive analytics are working well in ICUs and pediatric emergency departments and obstetrical care, like really, really good to decrease risk. And the reason I think we're going to build trust is we're going to find that risk is actually reduced over time as we start to use these more, not being blind to the fact that there is bias. There is bias in a lot of these models. And I want to make sure, really sure, that this model applies to my patient population specifically because my patient population might look different than the one it was modeled on. And also that these things still hallucinate. They're not smart enough yet. We can't just let them run amok and make decisions without us. We gotta double check. This doesn't mean humans are gone in this equation. It means we got to make sure we're on top of it, but hopefully some of the really easy stuff gets streamlined and looked after without us. And that's the automation part. So that's a bit of a long diatribe on, my view of AI, but I think it's super promising. It makes me super excited, which is why I wrote a 5-part series about it, this past year, because I think we need to talk about it in ways that make us comfortable with it and familiar. Many of us are using ChatGPT in our daily world now, and that's super interesting. I have a button on my browser that allows me to use ChatGPT instead of a search engine. Like if I have a question, I'm not just looking for a thing. If I have a question about something, ChatGPT tells me the answers, and now Gemini, so I'm not getting a list of 50 or 60 sponsored ad-based content pieces before I get the detail and content I need. It's curating things really well for me in the regular world. Let's do that in medicine. Are we more reticent to use things quickly in medicine? Sure we are, because the risk is higher if we get it wrong, right?
Right.
We don't want people to die. We don't want to get sued. We don't want these things to happen because we didn't pay attention with enough skepticism or enough of a critical view on this. So I think there are good reasons for us to be a bit laggards in the technology space. Because we're inherently skeptics in the way we're trained, we need that skepticism in order to be safe and to be doing the best thing for our patients. But we shouldn't let it be an excuse for us to slow down or stop.
No, I think that's incredible. And there is so much to unpack there, but I think it's so valid. Just want to make sure the automation piece that you said. So the role that AI would come in is like, for example, you said flu, there may be different strains. So in general, you want the population to get their flu shots, but you're saying with AI, it could catch patients that are more susceptible to the strain that year or that season, and you can
Perhaps,
catch
yeah.
them and flag them. Got it. Okay. And then the
The
predictive.
automation is really process-based. It's really, the automation part is really managing the business of medicine more effectively at this point in time, because we don't have that signal that tells about the strain of the flu virus versus the patient's susceptibility built into our systems to do that comparator. But the automation part is going to be the flow of people, care pathways, booking, navigation, chat bots, the ability to interact with somebody, getting the answer or something, getting the answer for you without even needing to talk to a person. That kind of thing is almost ripe and ready for us now.
No, and so valid. And building off of another point you said was predictive AI. And so I did a paper in the past year where in Ontario, just focusing on Ontario, we have that data available. So we are collecting certain data points, right? Because we have to reverse engineer that what data points we need. But that data is not necessarily accessible and not accessible in real time via an API, right? To build and strengthen your AI training model, you need to keep feeding it data. What are your thoughts on that to come over that hurdle so we can, build these predictive AI or generative AI models? Any thoughts on that?
Yeah, I mean, so we do want to make data available. We don't want to have unfettered access to personal information, though. So like privacy and security has to be built into this, meaning appropriate anonymization. I mean, one could argue you can't really anonymize anything now with AI because you will always probably be able to get back to the actual individual. But let's say you start aggregating and anonymizing and you're doing things at a population order, make those data sets available to all those who need them. That's important for research. It's important for education. Certainly important for the comparator analytics we're doing in practice. I don't want it sold. Look, I don't think it should be up for sale. Personally, ethically, I don't think that's the way to do it. I don't think that data is mine. I think it's my patient's data. I think we have to have those conversations around, like, they need to know what's happening with their data. Like, I'm not sure we have to consent for every single thing we do because there's a lot of implied consent in our world. In medicine especially, but we do need to make them aware. Like if we are exchanging data with the healthcare system, some of that's done by law, like we have to. We do that every time we submit a bill with the diagnosis code attached to it already, but there's a sense that at the other end, that data is also being protected. Do I know if I'm giving it to a tiny little AI company, what they're doing with it, where it's going in the interim, how they're learning from it? Is there profit to be gained or lost on that? Not just financial profit, but other forms as well. We're seeing lawsuits now, ChatGPT being sued by the New York Times. How did these models learn? They learned off of reading things. What did they read? They read newspapers and the internet, all kinds of stuff. So for sure, and I don't know that lawsuit will be anything, but they're really making a point about the fact that some of this stuff is proprietary, or in our case in medicine, very personal.
Yeah.
And we have to respect that. And so it doesn't mean don't do it. It means build the safeguards around it that ensure the protection of that privacy over time. And also survey for when it's going wrong. You can't just say we built it, it's good. You got to make sure you're checking it and testing it, and the people aren't hacking it, and that your nefarious things aren't happening by using data for reasons that we don't expect or don't look for. So auditing is important. That constant quality improvement piece is important. And we can't just say it's good, build it, go use it without those safeguards in place. But I think that's all doable now. So let's just get down to it. Get on with it.
That is so valid. And last piece before I move into population health, and we will wrap up, is how you said about biases. Like, for example, with heart attacks, based on the research that was done, when we say you have pain in your left arm, that is related to men. Mm-hmm. Women present differently. So I think to your point about biases in the research and the data that is collecting, that we are cognizant of various ethnicities. We are cognizant of socioeconomic status, right? Higher and lower socioeconomic status. That is important. We kind of jump over that a lot, but that is a key factor when it comes to an individual's health. So I think that's so important that you mentioned the bias piece. And then closing in on like the population health. I know you mentioned about how AI can use it. And I know in our previous conversations where you mentioned population health can still be evaluated without AI. Like right now in our current state, we can still use that to, treat our patients, catch them, and maybe not as effectively or as quickly as we could with AI in the picture. But if you could just dabble that, the importance of population health and how we can use what we currently have available at our fingertips to address that, because that's so key. I think, like you said, we look at individually, an individual patient, but overall population health and catching the patients that generally fall in the cracks is so important. So if you could just
Yeah.
shed some light on that.
Yeah, you're catching and you're applying programming for groups of people, at scale. I think, there is a massive crossover in my term of what I call population health and what many people call public health. And, we have in our healthcare systems firmly divided public health away from regular healthcare delivery, which I think is completely wrong. And we learned the errors of that during COVID, I think. And so we had way more integration of public health and family medicine and regular medicine and acute care as well during that time. And now it's kind of drifting off again to be its own silo. Like, I think we've got to think about our populations as being an entity as well that we can actually look at. It's almost like when you take, say, 150,000 people and put them all into one bucket from the point of view of knowing everything about them that we can know. And we start asking questions about that population and finding things that need changing or potentially educating or other things applied to them. And then have a program to do that. We can move the marker on certain things like, let's pick smoking cessation, for instance. That's a simple one. We can move a whole group of people along more quickly than we can one individual at a time, if we apply that population lens to it. Vaccination programs, screening programs. This is what we were seeing in the analysis of the early Ontario Health Team conversations, right? I mean, OHTs took a bit of a turn during COVID, or they kind of in many places stalled because of that emergency. But we're getting back to that now and saying, look, what can we do from practice level when we aggregate that up to a larger network? We aggregate that up to a population that has a community around it, including a hospital, various programs in schools or in municipal programs or fitness or anything, and taking into account cultural and ethnic diversity, taking into account all the social determinants of health, which frankly, in my electronic medical record, I don't even have a place to record outside in just pure text, right? Like, all of these things can be applied, and even that data may not need to be held in my EMR anymore. If I can get it from StatsCan or other places and start to overlay it, then you start seeing a population having a life around it as much as an individual does. So I think we don't ever stop looking at individuals, but we need to start looking more at populations, because we do find very significant signals, especially in the world of public health domains, that are perhaps of the interest to municipalities and provinces in a different way than individual care is, that can really do a lot especially in the world of prevention and management of chronic disease. So we're starting to do that work in larger, like, team-based models of care or regional networks now. And we were stalled with COVID. Everyone understands that, but we're getting to that now. And it also takes significantly good quality and well-aggregated data sets to make that happen. And as you've already described, we're starting to see those forming, and the ability to use that data for population-level analytics, legislated or done through the means of regulation, if not legislation, and then seeing the outcome from that. I think it's not going to be all of what we do in medicine, but it will need to be more of what we do in medicine. And I think it's possible.
I think that's so valid. I think we forget quality of life of a patient. And sometimes we forget, right? Patients include all of us. It doesn't matter your title, your profession. We're all patients. Maybe not today, maybe tomorrow, in the past, or a loved one. So quality of life of a patient is being able to keep them at home, keeping them in their community. Like you said, whether you call it population health, public health, it is allowing an individual to stay in the community and only go to acute care, to the hospital, at that extreme, right? If I can keep you at home, like you said, certain initiatives to allow you to do that so you can carry on, stay with your loved ones, that will improve your quality of life, and that will help alleviate some of that in terms of resource allocation, all that within the healthcare system. But I think we have to start somewhere. We're still individuals, like you said, but to address it also on a population level, whether, like you said, ethnic background, whether it be your socioeconomic status. There's so many things we need to be cognizant of, what some individuals may be more accessible to compared to another. There's so much. So I think that's so beautiful and so valid. This pretty much brings us to the end. I know, Darren, I just kept going at you. I was like, you have so much knowledge. And I was like, I wanted to, just pick your brain to grab that so that others can also get this opportunity to learn from you as well. So just to kind of wrap us up, I'll just hand it over to you. Any last closing thoughts, anything you're excited about, anything you wanted to add that maybe I didn't, tap into, that you did want to share as we wrap up for today?
Yeah, I mean, this is all narrative and storytelling, and I spend my entire world in medicine in the narrative space as well, because we are taking individual stories from patients, forming ideas around it, driving some kind of action plan. I think that same narrative conversation can happen to larger groups. I'm really excited about the pending transformation in primary care that we're seeing in many provinces now. Some are ahead of us here in Ontario, but we seem to have at least the beginnings of a mandate with the appointment of people like Dr. Jane Philpott to her role. I mean, things can all change with various governments and elections and things like that. But I think what we know now is the driving force behind that patient medical home kind of model, that team-based model, is very, very evidence-driven and very, very data-driven. And there is a need to fix the problems we have in primary care now, as evidenced by, 1,000-person lineups in Walkerton to get a family doctor. How did we get to that? It's shocking to me that we've come to that point. So we have to think about where this transformation needs to be applied and how to make it really quickly start to settle some of our major problems of health human resources crisis in every profession, frankly. Access for even the most basic of care for significant numbers of people that don't have any access at all right now, other than Emerge or a walk-in clinic. And we have to figure out how and learn together how to work well as a team to ensure that we understand these warm handoffs, that the data is available, the conversation, communication happens around the patient, not just with the patient discreetly one by one by one. It's happening in a wraparound kind of way. And ultimately what I want in this space, I want patients to have full access to their data all the time. We haven't even talked about that, but patient access to their data, there's strong evidence around how that improves their own self-care and self-management. And I think that's super important. We forget that 99.99% of the time, our patients are by themselves or with their family, not in front of me or a nurse or any member of the healthcare team. And if we don't complete that step of patient empowerment to do the right thing for themselves as much as they possibly can over time and lift them where they need a lift, then we haven't accomplished much, frankly. So we need to kind of get there. And I think about that very holistically. That's my work now in the consulting space. I'm bringing a lot of this to the provinces I'm working in now. I'm hoping Ontario will be quickly down that path, and we in Ontario can learn from other provinces that have gone before us and can do it well.
Yeah, no, and I think you wrapped that so beautifully. Like you mentioned, a family clinic, a family physician's clinic was open, and there, like you said, patients were lined up, thousands of them, and you're like, we need to address that. And the way you ended off with patient empowerment, like you said, the patient should be the carrier of their data because they move around. They're the ones that, they're interacting with their family. You name it. Even if I move from Ontario and I travel to BC just to travel, my data is here. If it moves with me, the physician there, the ER doc, you name it, is able to pull that data as opposed to repeating tests, knows what my allergies are, all of that. So I think that's so valid how you ended off with that. And that ties in with the theme of this podcast, right? Empower Speaks, Healthcare Talks. That was not planned, but it all came down to that, right? Patient empowerment, empowering individuals. So thank you for kind of closing off with that beautiful thought. Also, thank you for taking the time and just, dabbling into so many areas, your personal journey, sharing some of that wisdom, your thoughts on the shortage of family physicians, artificial intelligence, digital health, you name it, population health, and just wrapping in beautifully with a patient empowerment. So thank you so much, Darren, for your time. I truly appreciate it. So thank you so much.
I appreciate the opportunity. It was a lot of fun as always.
Awesome. Thank you.